Okay, so I'm at Loughborough University. The spelling is quite different from the pronunciation, yeah? And it's in the Midlands between Leicester and Nottingham universities. Okay, this work stems from a clinical need highlighted by Atul, who's not here today, and then he brought us the problem, and we've been investigating it for a long time. And we have other projects as well, which we have about, I think, 3 or 4 on the go at the moment. Okay. What I'm going to talk about is really stems from what other speakers have spoken about, is what to do when you use ultrasound in order to get a needle where you want it to be accurately, but not just by the expert, but also by the junior clinicians, because the patient doesn't really have a say on who's going to operate on them, who's going to inject a needle in the body, and therefore they want the same outcome, whether it's an experienced surgeon or a clinician or not. Yeah. So currently, quite a few have spoken about landmark-guided procedures that sometimes, unless you're quite experienced, you will have complications, you will have difficulties. And in the UK, NICE, the National Institute for Health and Care Excellence, have recommended the use of ultrasound. So I think everybody in here have bought into ultrasound as being a good modality in order to inject needles into the body. Okay, there are other methods, but they're more expensive. I'm going to just talk without the mic, sorry. Can you hear me at the back? Yeah? Can you hear me? Good, thank you. I'll just shout because I'm used to shouting without talking to mics. Okay, we have 2 types of procedures, real-time procedures and pre-puncture procedures. Okay? It's okay, I can do just, yeah. I'll just talk like this, sorry. Okay, real-time procedures, you're familiar with that, just to make sure that everybody understands what I'm saying. As well, it's you inject the needle into the body with the aid of the ultrasound. So for this one, you must have the needle in the plane of the ultrasound on the image. Okay? The pre-puncture one, this is our tool in demonstrative pre-puncture, is when you, or pre-scan, is when you scan the body and then you inject the needle afterwards. So what happens is you lose information. Yes, you target where you're going to go, you target the point where you're going to go into the body, but the orientation of the needle in 2 planes is lost. Okay? That's why, however, then ultrasound freehand, fortunately, can be a problem for some, like the likes of Atul and a lot of you, I guess, people who have been doing this for a long time, it may be easier, but for somebody junior, it might be very difficult in order to do that. And I've actually seen them because we had a lot of tests in the department, or clinicians who came either both at Glenfield Hospital, Leicester, I went there with a lot of clinicians, and also at Loughborough University where we've done some tests. And I've seen clinicians not being able to do a procedure using ultrasound imaging. Okay? So you have 2 solutions then, training, a lot of it, and unfortunately, the patient may suffer if the needle is pushed in at the wrong place, okay, and you hit the bone, say for epidural, there is a problem for the patient. Okay, or you can use technology in order to aid the process. Okay, and I believe that it's a duty of clinicians, if there is something there which can help them in order to improve the process, then they should use it. I'll explain all these probes later. Okay, so the difficulty then, when you use ultrasound, if you are in plane or out of plane, the in plane in here, you have to align the needle in order to get to the target in here, but also you need to maintain that needle along the plane, along that plane there. Yeah. So, and I've seen people working on turkey legs, Atul uses them, or legs of lamb legs as well. And I've seen people having difficulties in doing this. Okay, the problem with out of plane, I'm sorry if I'm teaching my grandmother to suck eggs in here, okay? So I apologize, but I just want to make sure that everybody goes on the journey with me, because I'm repeating the obvious in here to some of you. Okay, and here with the out of plane, the problem I've seen is that sometimes people cannot identify the tip the tip of the needle. So the cross section gives you a cross section between the needle and the plane, and therefore you think that the needle is where it may not be, and there is a problem there. So in here there is the angle also and the depth of that. So there are problems, and therefore we need to look at ways of solving such problems. As an engineer, that's what I'd like to solve problems. Okay, so I said that it's your duty of all clinicians to reduce the risk. I think my colleague spoke yesterday about reducing the risk and how do you assess it, and if you have something which may help the procedure, you need to take it on. Okay, so we're going to use assistive devices. I'm going to start with the real-time. Okay, real-time procedures. What we have developed. There are, by the way, there is a real-time guide in the market, but when Atul assessed it, he found that it had limitation. It wasn't flexible enough. So that's why we embarked on this work. And then we started with real-time, and then we went to pre-scan, pre-puncture, and we looked at different other things. So we start from one thing, and it evolved. Okay. So in here, what we have, I'm using a GE probe in here because they gave me 2 probes a long time ago. And with the software as well, CAD software, computer-aided design software, so we can use them for our design. And that's why I've used them. The probe in here, this attachment, the bracket, attaches to any probe. In here, it's attached to a ultrasound GE. This is the 12L linear. Okay, so you attach the guide in here. You attach this first to this one. In fact, you put the sterile cover first. You push this on top because this is sterile. It's one-time use. Then you push this down in here. Okay, you can do this at any time during the procedure. Okay, what we have, you then target. You find you do the scan. Yeah, you find where the target is. Say it's down here. You measure that distance, and from that distance, using our app, will give you an angle where you move this one to. Okay, and we also give you the depth. The needle has to go into the body, the length it has to travel. Okay? So that length there, we give you that one, but also the angle there. And that will get you to the desired point. With respect to the end in here, because we use this as our datum, and the center line as well. Okay? So, and with our method, you can actually target any point, any target within the image of the ultrasound. So you don't have to maintain it on the actual center line. And also what we've done is that you can, once you put the needle inside the body, if you want to remove the assistive device at any time, you simply pull this clip off, yeah, and take this one by unclip it in here, or simply leaving it there. So you can then go back to your old ways if you want to. So we don't restrict the user to use the device. Okay? This test in here was at Glenfield Hospital, and you see some of the clinicians there playing with the equipment. And we've done this so many times. Initially with Atul and Vipul and Yahya, who is here. Well, he's around, I don't know. Yeah. Sort of a one-off. They come to the lab, we play, and then we go back and they comment and so on. So it's a lot of, the design involves a lot of iterations. Okay, here just to explain what I've just said, you measure that depth in there. From that depth, we can give the angle in here as well as we give that distance. And you don't have to be along the center line. You can go anywhere in that plane, because sometimes you cannot push the probe to where you want it to be. So your target could be away from the center line. So by knowing that distance and that distance, we can give you the angle, orientation, as well as the depth of the needle. So you can get to the right position. With regard to the depth, you can either mark the needle, or you can put the bead in there and fix it. So you can actually physically limit the depth of the needle. So you cannot just push it too far, especially if there is something in the area, in the vicinity, which could be dangerous if you over travel. So it's safe. It actually allows a safer process. Okay. Okay, for pre-scan, pre-puncture procedures, the best one is actually using the spine, because you're limited. You really will need to put the needle along the center line of the probe. So you measure. I'll go through this later, step by step. Atul has done it with with the probe, so we'll go through it in here. Our tool in here is demonstrating how to find where you want to be. You do pre-scan first, and then once you find that, at the moment, what clinicians do in general, they blanch the skin, then they find the center line either by doing 2 cross lines or getting the back of the needle and pushing it at the center of the probe, and that gives them the entry point. But what you lose is you lose the orientation, the angular position of the needle. Yeah? So you could hit it if you could get the center here, but if that angle is wrong, you're going to hit a bone. And that's painful, I've been told, for a patient. So again, expert or clinicians with a lot of time finds it a lot easier than junior ones. And a lot of people are here, my colleagues, saying that epidurals, when their partner had an epidural, there wasn't a good experience, and that's not what we want to hear. Okay, we want everybody to have the same positive experience. Okay, so there is a problem then. What we need to do now also, in order just to align it in one plane, sometimes when you have big patients or patients who their spine is not straight, then you need to orient the probe in 2 planes. And that's what we work on. So it's 2 planes. It's not often needed, but it is sometimes needed. Okay. So we've got the common technique, blanching, etc. The difficulty is that the insertion point, yeah, you have to mark it, but then the orientation in the 2 planes, sagittal and transverse planes, are lost. Also, the insertion length, sometimes you can measure it, you can limit it, but you need to make sure that you don't overshoot. But you can still use a loss of, not pressure, a loss of resistance once you approach. So if we say you're going to have to travel, I don't know, but say 30 millimeters, 3 centimeters, you stop at about 2.5 centimeters, and then you start using your own technique of loss of resistance to make sure that you're in that space. But that just gives you additional really confidence. Okay? And this is the device, which tomorrow I have another session at 9:30. I'll bring the equipment in here, which I've got, which can show you, and then I'll show you how it works. This is, by the way, I'm going to retract sort of a real-time system, which I have in here. There's a needle there, the clip there, which you can push back. You can remove the attachment at any time. You can re-click it on. And the beauty with our system as well is that you can use the same guide for both in plane and out of plane. And if you decide halfway that you don't want to do in plane, you want to do out of plane, you simply take it out of there and click it on the out of plane. So you have that. That's for the real time. For the pre-scan ones, with this one, I will explain again, but it's best to do it in more than one time. Okay, we have this device in here which attaches to the probe. Okay, and then you align. Once you've done your alignment, you push the two we call them pens, against the skin. You lock them. You put 2 dots. Yeah, you put 2 dots in there. You take this away. You remove the probe, and then you put a guide in there. You push a guide, which is all sterile. You just throw this away at the end, and you push it in there, and you put the needle through. Okay? You could put either the needle through first or later. Okay? And that, by putting this back onto the 2 dots, I have a tripod. 1 dot, 2 dot, and the base of the probe gives me a tripod. Therefore, I go back to the same place. Okay? So that's easy. But then, that's the design side of it. But once you design, it's how much does it cost it? Because at the end of the day, the NHS in the UK, medical services throughout the world want to reduce cost. So you need to look into reducing cost. And reducing cost, there's manufacturing. How do you make manufacturing simpler? So there is, I'm just showing you this one in here. It's difficult, but I'll show you tomorrow. Instead of putting a screw, I could put like a door stop. I don't know whether you're familiar, because sometimes when you want the door to remain open, you push a wedge underneath, and this is the same thing. By just clicking it, I then locked it. And this allows me to do this component in one go. With the injection molding, I can put 2 components, and I can make that in one go. And that will reduce the cost tremendously, because injection molding, which is a means of making a lot of medical equipment, is very expensive.
So
Sorry, should I be quick? I'll finish very quick. I'm sorry, I was enjoying myself there. Okay. There's another there's another guide there which I'll go again tomorrow morning to explain. This is ideal when you want to go into. Sometimes you have this space in here where you want to push the needle within that space. Okay, you cannot do it with real time, and if you want, even with pre-scan, you cannot do it because you have to mark it. So with this method, I can target anywhere in here, but with the needle going anywhere in that space. And again, we have an app for that one as well to help you position that one. Okay, so we have an app. I'll explain tomorrow. This is on the left hand, your right hand side there. There's the app in there which can show. Is that okay for a few more minutes? Is that? Sorry, yeah. Okay, thank you. Sorry about that. I'm just. So this in here, an app. So you decide what you're using. Fixed for this one in here, for example, fixed depth or fixed angle. If I want to have an inject a needle at certain angle or certain depth with respect to the probe, I choose it, and then I'll get the information from there. But again, I'm around, and then I can explain this at any time. And then we also developed one for the Androids, yeah, an app. And here, this is a PC where you can have the image on the PC by clicking on the dot itself. You can get all the information needed, and that will help you and gives you the information. There are other designs, which again I will explain tomorrow. They do the similar things, but slightly different. And these are the usability tests. Okay, you see Vipol there and Atul and Yahya there. I thought I'll put the images there. Yahya, Atul, Vipol, and then we did the tests with using gel, agar gel, and then we simulate either with an olive inside there or water with a tube open, and then put liquid in between, and that simulates a vein or a nerve or whatever. Yeah, and these are we did some testing with proper documentation. Yeah, and back to the design, drawing board, and so on. So we had to improve quite a few times. Yeah, here I've just showed you a picture. You came too late. So that's okay. I think what I'll do, I'll maybe show this tomorrow if we are running out of time at the moment. And this is Atul doing demonstrating the system on me there not long ago. Okay, so I'll show that. What I would just like to show very briefly, if I may, is that it's a long journey. It's not easy, and I encourage all of you actually to if you find a colleague in the university in engineering to get to talk to them and see whether you can advance science and for the benefit of the patient. Yeah, the clinician, yeah, but at the end of the day is the patient. Okay, so potential, and decide what is it you want to do. Is it for impact? Okay, so you want a lot of publications, etc., to make yourself famous, or is it for just humanity, or is it because you want to be very rich? Okay, so try to make that decision at the outset. Okay, and then sometimes actually, if you just do it for research sake, you may reach commercialization. But if you do that, you have to be careful with IP, intellectual property, who owns it, and also confidentiality. Okay, so I'll just go briefly into here. There's a design process where you really have to get the user need. You have to have a clinical need. Without clinical need, forget it. Yeah, if you don't have a proper clinical need, because yeah, then you need to that. And then some clinical needs are more important than others. Yeah, and then you go to the design stage and you design something. You then verify it. You go back to check and so on. And you go around this process quite a few times before you get to here. And once you get to here, then you do some internal validation through clinician, and then you go through external, you produce something which looks like the real thing, and you do proper testing before it goes into market. And it's a long process. Medical, I wish I never went in medical engineering as far as research, because it takes too long. Yeah, but I am where I am. So, yeah. Okay, so but whoever you work with, yeah, you need to discuss this right at the outset. And if you don't trust a person, please don't work with them. Okay. A lot of it based on trust, and I've seen people being hands burnt. And also, you have to have an IP agreement with Atul, Vipul, myself. What we do is that they come up with an idea, and then from that point onward, we all share the IP. We're common. Yeah. So if they suggest something or I suggest something, it doesn't matter who came up with the idea. Once you started the journey, it has to be joint together in the journey. Because if you start then saying, oh, you came up with the idea, therefore it's your IP, then you get the royalties, no. It won't progress, okay? And then confidentiality. Even in here, if you speak to me or speak to anybody, at the outset say, I'm talking in confidence, okay? Because if you don't do that, you've lost it. You cannot patent it afterwards. So be careful on that one, okay? So I think I'll just, okay, the journey in here. And the other thing, I love this one, yeah? We all engineers, we have a lot of things in the valley of death. The valley of death, you've done all the work, you've proven it all works, yeah? But then you need commercialization. You need to take it into hospitals, yeah? How to do that? You need a lot of money. You might find a rich colleague, okay, who can give you money to cross that, or you can create your own company. But that is the problem. I've got a lot of current in my lab sitting in here in this valley of death. Okay, I've got a great idea, and then, unfortunately, it stays in the lab. You need commercial aspects in it. So what you really want is somebody, when you've done that, you want somebody or company to take your ideas and then make that bridge in here, yeah? Build a good bridge, and then great impact financially or commercially, whichever it is. Okay, I think I'll stop there and I will continue tomorrow. Sorry about that, I took too long. Thank you.
Schedule. I would like to suggest that questions will take during the lunch break. And before I end this session, I would like to also announce that tomorrow's session we are starting half an hour early. It will start at around 9:30.
Very good morning to you all. First of all, I have to thank the organizers for a wonderful, unique conference in so many ways, because I have seen the audience of delegates are running, jumping one hall to other hall to attend the sessions. Here, everybody is a bit relaxed, including the faculties, delegates, because it's the only one hall, and we never missed a feeling of guilty of missing the sessions. And the topics are also very unique, especially just the Professor Kadar. I never heard a topic lecture by an engineer and a medical physiotherapist. So many people are there. In such a way, the unique conferences. Topic also very unique. Faculty, delegates, everybody is unique. Such a wonderful, relaxed hospitality in every aspect. Thanks to you all. And coming to the topic, chronic abdominal wall pain, really a diagnostic challenge to the clinicians, because so many times we are missing these clinical conditions. Can you see what are the things you can see in this picture? Most of the times it would be viral in WhatsApp. So now you can see both the bricks and cigar. Those who missed a cigar, don't worry about that, because unless your mind looking for the cigar will not be revealed in these pictures. This is the same thing we are going to face in the diagnosing the chronic abdominal pain, whether it is arising from the viscera, whether it is arising from the wall itself. Unless you have this in your mind, the wall itself is a source of the pain, definitely we are going to miss. This is not the local phenomena, it is the global phenomena. So, what the literature says about, can I have the marker? Chronic abdominal wall pain. So, this is the study released on 2014 by the Christopher Costanza. The chronic abdominal wall pain is a common unrecognized disorder. And again, the 2013 is a wonderful study from the Dutch. He himself declared the clinical relevant portion of the patients previously diagnosed as a functional abdominal pain syndrome or irritable bowel syndrome changed into the acute, that means anterior abdominal cutaneous nerve entrapment syndromes. So quite significant patients are diagnosed wrongly as IBS. And another study, 2015, had highlighted the military physician has to be aware of abdominal wall pain, and they have to be taught with the simple Carnot sign to alleviate the chronicities or eliminate the chronicity and avoid unnecessary testing and for the correct diagnosis. So another past 15 minutes I am going to cover what is chronic abdominal wall pain per se, what is the incidences, how the pain is produced, a bit on pathology, pathophysiological aspect, what could be the clinical feature and how to diagnose it. So history, how the clinical condition is evaluated. It was reported in the 1972, that is the 18th century, by J.P. Franklin as peritonitis muscularis, because he thought the parietal peritoneum could be the cause for abdominal wall pain. And he himself noted on the 18th century itself, lot of the clinicians or surgeons are missing the source of the pain is from the abdominal wall, rather than they are more concentrating or blaming the viscera for the pain. But 20th century, J.P. Carnot, he revolutionized the Carnot sign, as he himself described the cause for the nerves which is supplying the abdominal wall. He himself suggested that is the neuritis is the cause for the abdominal wall pain. But the nerve entrapment was the cause. This was first described by the 1972 Applegate as the abdominal cutaneous nerve entrapment syndrome. So it took almost 2 centuries to define or to evaluate as a clinical conditions. So what is the definition of abdominal wall pain syndrome? I can't find any comprehensive definition. The description is there. So the best description I have seen is by the Sharpson in 1994. He described as a non-visceral abdominal pain. It itself is a self-explanatory. Even though chronic abdominal wall pain caused by so many etiology, the most commonest is the abdominal cutaneous nerve entrapment syndrome. It is called by ACNS, and both the terms are always interchanged. So, what is the epidemiology? Among the studies we have got to see that the comprehensive or the projected evidence is going to be the 1 in 1800 patients. Among the abdominal wall pains and negative prior diagnosis, the prevalence jumps to 15 to 30%. Women has little bit higher priority. The projected age group is the 30 to 50 years. So this is the one, again the study from Netherlands, the European study, the review article has thrown lot of light towards the epidemiology as well as the pathophysiology. This is the one interesting study. These two, Abdi et al. And Hall et al. Have found the incidence around 3% to 15% when there is the common patients, the common pool. That means chronic abdominal pain without exclusion of the intra-abdominal pathology. Maybe they have taken, why the 3 to 15%? Maybe this population is from the emergency clinic where the patients came as the abdominal wall pain. This may be the specific specialty clinic. That's why the incidence little bit varies there. When the intra-abdominal pathology is ruled out, the chances of becoming the abdominal wall pain jumps to 20 to 30% in these studies. 97 and 98 by Thompson, Francis and Gray et al. And Julian et al. All the things jumps to 15 to 30%. So what is the pathophysiology? Also knows the name itself suggests the entrapment. Why that is unique in the abdominal? Because of the nerves which is supplying the abdominal walls is little bit unique in the course, because it has to travel through the abdominal walls and take acute turns here and there. That is the places where it is going to be the risk of entrapment. So in anterior abdominal wall, where it is posterior rectus sheath, it crosses and takes the acute angle and come the superficial sides, again takes the acute angle. This is the most site prone for getting obstructed or getting entrapped by the fibrous sheath. by anything arises from the intra-abdominal pressure or any injury here or something like that, or any abdominal parietal wall, abdominal wall pressure can dampen this nerve here. That's why it's more risky to get trapped here. That is the reason for entrapment syndrome, and it may likely to occur here also. Not only these nerves, again whatever the cutaneous nerve supplies in the abdominal wall may get entrapped at any stage, because most of the times it's passed through the aponeurotic sheath, because the abdominal wall is never be muscular in all around. Sometimes it's muscular, sometimes it's aponeurosis. So at any time, any nerve has to be passed through the aponeurotic constriction or sheath. So it may be likely to be get entrapped at any time. So these are site of entrapments. These are the foraminals through the aponeurotic foraminals here, and sometimes ilioinguinal, iliohypogastric nerves through the emerging from the deeper plane. So what could be the clinical features? So they did 120 emergency department admission for acute abdominal. 23 out of 24 Carnot sign patient has the normal laparotomy. That means the negative laparotomy. Among the 72 patients, the only 2 patients with Carnot sign positive were related to spinal meds. When combined with other clinical history and physical examinations, this is going to be a fairly reliable, respectable clinical test to diagnose the thing. Very simple. But the Carnot test alone has a 78% sensitivity and 88% specificity. So how will you diagnose this now? So this is one of the very good review article of Journal of Pain by the Corona. 28 articles reviewed. They have certain 17 articles. 15 of them are case studies series. Only the 2 is the RCTs. But it has come up with a clear-cut, specific diagnostic clues to diagnose this clinical condition. Number 1, unilateral local regional pain, abdomen lasting for at least for a month. The presence of unilateral tender spot, the circumference is not more than 2 centimeters, that is always less than 2 centimeters or 2 finger breadth. It is not a very broad area or widespread area. And positive Carnot test. And positive skin pinch test or altered skin perception to light touch or cold area of the most intense pain. Sometimes it's called a Coover sign. And the temporary relief to the pain response to the trial injections, minimum of 50% pain relief to the local anesthetics without any guidance. Negative imaging of the abdominal wall, laboratory findings with no indication of inflammation, all the things are there. It is very easy to diagnose this clinical condition. But again, the study from the Netherlands has come up with a nice 18 questionnaire to diagnose this chronic abdominal wall pain. The point number, the score is the 10 is the cutoff value. They put the most of the 94% sensitivity and 92% sensitivity. But most of the things are almost, we can see the clinical features. So, what are the site of tenderness usually we'll see in chronic abdominal wall pain? According to the Gosdansa, the right upper quadrant and above the umbilicus is the commonest sign. But by the Van Essen has scored this one the most common site, mostly on the right side along the lateral margin of the rectus muscle. So many things are enumerated. The 3 important things: the rectus nerve entrapment, thoracic lateral cutaneous nerve entrapment, ilioinguinal. These are the major causes of the nerve entrapment. Other causes are idiopathic, herpes zoster, and hernias, and spinal nerve irritations, slip rib syndromes are some of the rarest one. But the endometriosis falls sometimes in between the parietal peritoneum or the purely muscular when the previous surgery was there. So how little bit on management, even though it is not undercover, I just 2 slides to management to completion sake. Again, the same Corona has given a little bit guidance towards the management. The systemic drug administrations, the amitriptyline lidocaine patches combined with the paracetamol has good results. Imagio et al. Reported the pregabalin which has only partial effect. Anyhow, The combination of the interventional technique in order to facilitate the patients will recovery improve overall quality rather than the drug treatment alone. What are the interventional techniques? Again, the evidences are not very encouraging us to go for everything, but the simple things you can do depending upon your clinical case and depending upon the needing. The trial point injection can be done. It will have the purpose to both the diagnostic as well as the therapeutics sometimes, and still the evidences are 2C plus only. So what is the major challenge? This is again the one as in has cautioned us why this condition is frequently missed. He conducted that thing. He parallelly they concluded these reports also that more than 80% of the responses are confirmed. This is conducted in the 2013 only. 85% of the responded doctors confirm there is never heard of these syndromes, and 18% of the senior surgeons were aware of this clinical entity. Only the 18%. So it is not surprising the doctors delay in diagnosing chronic abdominal wall syndromes is substantial, and many patients with the ACNS remain undiagnosed. 2 days, 48 hours pain relief with the local, then repeated injections of 2 episodes we gave with the steroid, and she had a good pain relief of 3 to 6 months. The second case is one of the very strange case. The patient, 50-year-old school-going boy, developed pain after removal of hemangioma. This is the area the hemangioma removed. This is the painful area. He never allowed anybody to touch here. We tried to do that under local ultrasound, but he never allowed me to touch it. The patient was taken into the operation theatre and sedation, and then only we can did the procedure. No local pathology, radiological investigation normal. Pain not relieved by the regular analgesis. Considered malingering and sent out from the school for his aggressive behavior. We did the ultrasound guided in the lower intercostal nerves, and first injections with the local. He had about 3 to 4 days pain relief, then subsequent 2 to 3 injections 1 month apart. We give almost a year pain relief. Is still the boy is doing well. The third one is I am not very sure about whether it falls into the this case, and 50-year-old CA prostate with the skeletal mets, pain after the palliative artery into the pelvis, inner groin and upper scrotal nerve area was there, exactly where the gentle branch of centrofemoral nerve, not relieved by the analgesics even with the morphines. We did a trial ultrasound guided, and the patient had a good persistent relief, but second dose for the with the local steroid doesn't have the good relief. We gave the another drug that also very short-term relief of 30 days only. But every month he comes there, and I'm missing for the past 2 months. Most probably he would have been passed away. So in summary, it's not a clinical condition by elimination. We have to be keep in our mind. It's a condition we have to always. There's a possibility of that. The chronic abdominal wall pain or the abdominal cutaneous nerve entrapment should always be considered in the difference diagnosis of the chronic abdominal pain. Should be always in your mind. Sorry. Specific diagnostic steps to be followed. The multimodal biophysical approach should never be ignored in all cases. Interventional techniques alone may not be adequate. Systemic drug administration following the guidelines of the neuropathic management may not be helpful, but it will be helpful along with the intervention technique. Multimodal approach is always beneficial, but the best approach yet to be defined. Further research to be needed to throw more lights on that. With this thing, I conclude my lecture. Once again, I thank you for all for the patient listening. Thanks a lot. If you have any questions, I'm ready to take with.
Thank you, Dr. Kumar. That was a very comprehensive introduction to this complicated problem.
Injection of neurolytic for such pain. If you inject neurolytic for a patient, if he's no cancer, he's going to have on the future TF fermentation pain, and you transfer it from just a simple pain to a neuropathic pain. So I prefer even to do simple nerve blocks and to do cryoenergies if you have it. Radio frequency or nerve lesion in this area will transmit condition to be a neuropathic pain more than the bigger.
Procedures should be followed only after the diagnostic confirmation of efficacy and diagnosis. But we have seen in our cancer institute, a lot of the abdominal wall pain is there, where we have no other option. Sometimes we are, there is a lot of studies with the TAP alcoholic injections is there. We tried with these things, and when the patients after neuroleptic or pain relieving interventions into abdominal, so the celiac plexus block, pelvic plexus block, epigastric plexus, inferior epigastric plexus block, the patients still have the pain over the abdomen, and where we thought that the abdominal wall could be the cause for the pain. We had few cases we did with the diagnostic TAP. Then we decided why can't we go for neuroleptic injections, because there is a few studies there with that. This is not for the benign conditions. It's that is added as the option is that. Thanks for pointing out because some may think of that it may taken for the wrong way.
Dr. Dogan.
Quick question, do you do pulse RX?
Yeah, that's what I'm saying, that the pulse are of a particular nerve, unless we diagnose it, we can do that, but very difficult to see the intra-abdominal nerves, because if you can't see the nerves, even ilioinguinal hypogastric, very unfortunate to see the nerves, even the post-operative clinical conditions, very difficult. So most of the things are plain injections. So the role of pulse RX, if you are very fortunate, if the one single nerve is there, the repeated local plus steroid is not going to be helpful. We don't have any option. Pulse RF can be done. Von Cleef has come up with a lot of pulse RF these things, but it's only to see evidence himself he suggested. So up to us, if you have the RF, if you have the patients with the persistent pain, this thing, if you are fortunate enough to see the nerves, you can do that.
What I've done in this situation is I've just flooded the dark lane and then pulsed the fluid which is there. But there are, I'm sure we can carry on with this discussion, but unfortunately we are restricted by the time we have. Thank you, Dr. Kumar, again for this excellent lecture. And I'm sure we'll be there to answer some more questions during the lunchtime. Following Dr. Kumar is Dr. Ashok Saxena. He is a professor and head of anesthesia at the University College of Medical Sciences, University of Delhi. He's a fellow of the National Academy of Medical Sciences, and he was a member representing Asia and the Scientific Committee of the World Congress on Pain in Argentina. And he is kindly going to share us his experiences and thoughts on the diagnosis and management of chronic pelvic pain in females. Thank you.
Very good morning and good afternoon, of course. Yeah, that's right, going to be. Honorable Chairperson Dr. Subramaniam over there, and learned audience, Dr. Ansari, welcome. At the very outset, I wish to express my deep gratitude to Dr. Sita Ram, thank you, who is hosting such an excellent conference, and of course to Dr. Anil Agarwal, who has taken all the pains, and of course Surjit Gautam and many others who are there. Well, 6th one, my heartiest congratulations. I attended your Agra one, Delhi one, Jaipur one. After that, there was some break, but I am back again. Thank you, Dr. Agarwal. Thank you so much. Well, greetings from University College of Medical Sciences, New Delhi. And as Dr. Subramaniam already said, it's a very complex problem. It's a private agonizing syndrome, which I am sure. Because you see, when we talk of visceral pain, it's supposed to be so diffuse, and I'm sure. Can any one of you tell me that how many factors are already affecting this visceral pain, which low back pain is not being affected? If I talk about your eating habits, talk about defecation, talk about urination, talk about menstruation, and talk about the sexual encounter, everything is affecting this particular pain. So it's a very complex entity, no doubt. And I'm sure I don't need to enlighten you on the definition, but yes, it's something which is lasting. Obviously, non-menstrual pain we are talking about. 3 months or more than 3 months with or without a clear organic pathology. And that's the beauty of chronic visceral pain, that it can happen even in the absence of an identifiable pathology of the organ. Always remember that. Well, what exactly is the neurobiology? I really don't want to bore you with that, but yes, you have the both sympathetic and the parasympathetic component, and that's what you have, a kind of visceral hyperalgesia. The afferent innervation of one pelvic organ may adversely influence and sensitize another organ. Way back in 2005, it's a very important one, research which came out. And that's where we have the visceral hyperalgesia, that's where you find. But always remember that when we are simply taking the example of even pelvic adhesions, remember that the degree to which there is an inhibition of the movement of one organ in a particular angle, that also varies. That's why you can have a lot of inter-individual variation among different patients. And obviously you have multiple causes like the multiple colors over here that you are observing. But the topmost three are the commonest causes: endometriosis, pelvic adhesion, and pelvic congestion syndrome. Others are, of course, tuberculosis, again very common in India. But you have some of the rare entities like interstitial cystitis and vulvodynia. Many of the patients we have dealt with, they also give you, really a challenge that how exactly you can manage in the absence of a clear-cut recommendation. You can also have, it's also known as migraine of the pelvis, and you have the entity like painful phantom pelvis, that even if the organ or even if the hysterectomy has been done by the gynecologist, even then the pain is persisting. So even in this kind of scenario, what exactly you can do? Well, this is where you find that some of the patients may present with this kind of entity, and psychological evaluation is very important over here. The amount of anxiety and depression that you will come across in these patients, right? And, inability to sustain relationships and all those kind of things are very important when you're talking about pelvic pain. I'm not talking about males, but then these are the commonest causes, and this is where you find that one of the Indian article which has come up in 2016, and that's where you find that these are the common causes. Even otherwise they were there, but he's enlightened a lot about, this is from UK, and he is published in the Indian Journal of Urology. But some of the rare causes can be dilated pelvic pain, sometimes don't come across, and that's where you find at CT finding that even 47% of asymptomatic women would be having pelvic pain, and dilated veins otherwise are found in 65% of Paris women and 10% of non-Paris women. So you have to have a proper differential diagnosis, and this is where you find the abdomen and the pelvis. I think let us not forget even things like irritable bowel syndrome, IBS, which is a big challenge and the biggest attendance you can have in the gastroenterology OPD in relation to IBS. We'll talk more about it in the end. And this is where these are the common presentations. You will have dysmenorrhea, dyspareunia, infertility, and all those kind of things which are there. And what very beautifully Dr. Kumar was talking about, and this is where we had one patient who was refractory to any kind of therapy, and then further we asked the surgeons to explore, and surgical exploration revealed a suture around the genital branch of the genitofemoral nerve. So, that's why Dr. Subramanian said it's a really very complex problem. You really have to go into the depth at what exactly is causing this pain. So the miscellaneous causes, yes, we have dealt with. This was one lady from the French embassy in New Delhi. Case was referred to me by my friend, and she used to be. She was actually a half marathon, that means 21-kilometer expert, and she actually had osteitis pubis, and so you can have all these kind of different reasons altogether, miscellaneous causes. But let us not forget, I know tomorrow there is going to be a talk on the cancer. I think I can ignore it, but the important causes of malignant pelvic pain will be direct tumor extension, perineural invasion, and hypogastric plexus spread. But yes, you can't forget the carcinoma of the vagina, rectum, testes in males, and uterus and cervix, and descending colon. There's some attempt has been made to evaluate the autonomic functions, and this is where in 2003 the COMPASS score on the mean overall composite autonomic symptom scale. The high score means a greater autonomic dysfunction. So this is something we should not forget, that these patients always have been undergoing. What Dr. Kumar talked about, this is one of the typical patient who actually had the Carnett sign positive, and this was referred to us by our gynecologist colleague. We have a very good rapport with the Obs and Gynae department at our college. For the last 30 years, we have been practicing the pain management. Now you can see the amount of depression, the anxiety that's so obvious from her face, and these are the points which we have marked. And actually, she underwent PRF, what actually he was talking about, the pulse radio frequency management, and we got good. So actually, the pain intensity, I'm sure you will agree with me, is not proportional to the amount of tissue damage. The pharmacological, I don't have to talk about, but most of the cases it is amitriptyline, and the mother and father of all the drugs, the gabapentin and pregabalin, they fit into, but not always, remember that. And I don't even have to talk about this, and I think I can ignore this one. The evidence in favor of acupuncture for abdominal wall and even for pelvic pain is somehow frustrating. It is not good. But yes, attempts have been made. but the results are not good, the evidence is not good. But this is one study I thought I must bring it out over here from UCLA in California, and that's where they use these points. These points have been used. We have been practicing acupuncture for last, of course, started from 87 to 2001, but after that, it's all advanced pain management which has come up. And, so all these points have been used in acupuncture stimulation. And trigger points, yes, Dr. Kumar talked about, and let us not forget these trigger points in the abdominal wall, sacral, perineal, and vaginal wall. So that's another thing which you always keep it in mind. And this is one of the structured protocol, and this is where you find, I thought I must bring it out, acupuncture having been given 2 times a week, and then the Magil pain questionnaire that was assessed, and the VAS scoring and all that. There was improvement in the social activity in 65% in 6 months, but this is one of the study which I thought I must bring it out over here. Yes, an attempt has been made, and we also used Botox in some of these patients, but we also use Botox in the intradetrusor muscle, taking the help of our urologist. No doubt it is expensive, but then sometimes when IC, is something where there are 2 nursing tutors who have been my patients. And we failed to, you always start with conservative treatment, go on to minimally invasive, and then you escalate accordingly. From minimally invasive, you go on to large, more invasive, and that's where I won't call as intradetrusor Botox being more invasive, but this is what really helped them. But the cost factor is there definitely, because if you use actual Botox in India, it costs around 16,000 rupees for 100 units. Going into the basics, the same peripheral and central sensation phenomena operating, and how can we forget, Subhash Jain and Plancarte in 1990 when he brought out. So I'm sure there's going to be something about superior hypogastric plexus block tomorrow, but the audience needs to know right now over here that when you go on to those blocks, how exactly you need to understand that near the bifurcation, you have a retroperitoneal structure. We mostly have been using superior hypogastric plexus block. Sometimes I combine superior hypogastric plexus block with your ganglion impar block or ganglion of Walther block. But lately I have realized that even inferior hypogastric plexus block also does the job. Though it is a diffuse area, it's not a compact area as compared to the when you plan for superior hypogastric plexus block. So this is something which is known as conscious laparoscopic mapping, which we have done, and there have been reports in this, and this is where you find that it doesn't help much or when you follow them up for about 6 or 12 months period. And I think superior hypogastric plexus block has its own history, and Plancarte the first time when he brought out this, and followed by Casasola, De Leon Casasola over there. And this is then you find that attempts were made. We also made an attempt on continuous superior hypogastric plexus block, and obviously I need not repeat the conditions and how exactly you need to give this block. You can give it C-arm guided, CT guided, you can give it basically an ultrasound guided block, whichever way you want. But especially in advanced malignancy, as always, when the anatomy is distorted, you need to give, you can give a CT guided block also. So definitely, but what we have seen that in 2/3 of these patient block was preceded by, this is what we do, single shot L4, L5 epidural, because it enhances the patient cooperation, reduces the reflex spasm and ameliorates the discomfort and reduces the patient movement. So we found that it is useful, bilateral one. But then recently, last 2-3 years, we have made an attempt, we have been very successful with the transdiscal placement of the needle. That's at the L5S1 transdiscal superior hypogastric plexus block. Now this is where, of course, all of us know that you can use Chiba needle, 20 gauge, and analgesia is there due to interruption of the sympathetic outflow to the pelvic organ. All of us know that when you plan for superior hypogastric plexus block, you basically target towards the lower 1/3 of L5 or upper 1/3 of S1, and this is when you are giving it bilaterally, not the transdiscal one, but the lateral approach, and this is where I was talking about the lower 1/3 or upper. So you need to be very cautious, because sometimes there can be a big transverse process of L5 that creates a problem. Sometimes the high arched iliac crest can also produce a lot of obstruction. That's why the transdiscal approach has proved to be more useful, though the opinion can vary among the pain clinicians. And this is when you use the contrast, almost the dye hugging the spine, and that's a view that you can make out, semilunar spread. And of course, we also made an attempt for catheterization, and we were successful with that also. So this is where you have, of course, anterior approach without the ultrasound guidance, I would say, is very messy. We should not attempt, but yes, under ultrasound guidance, people have done it. And this is, of course, I think I can ignore this one with one of the study that we conducted in patients with this was basically endometriosis, not the malignant one, and we had two groups where we used bitophenol. Another one was this, and without bitophenol, and of course the catheter was inserted, and this is where you see the kind of spread of the dye that you have over there. But in these patients, along with all those, the SFMQ and global perceived effect and the NRS scale, we also did, P300 because we were worried about the cognition. And when you talk about the event-related potentials, that's where the P300 gives you an idea about the cognition. And if you take into account the latency, the absolute peak latency, and take into account the inter-peak latency between the two waves, we found that there was an enhancement following this block. And this is where we saw that yes, definitely the cognition improves. In addition to the pain relief, we found that the biopsychosocial, because if we say chronic pain, as a biopsychosocial event, we need to prove that yes, the cognition also improves with that. So with this particular study, we found that yes, effective and safe modality, and we found that yes, the P300 as an objective parameter we had used in addition to all those, the NRS and the short form Maggle pain questionnaire. I'm sure we're going to have a talk tomorrow, but I thought we also have made an attempt in collaboration with radiology. You always need to understand the basics sometimes, and especially for, we're not talking about brachial plexus or a lower limb. When you're talking about this is where you see, I'm sure you can appreciate the fifth lumbar vertebra over there, the left common iliac vessels and the right common iliac vessels, and this is where, I'm sure you can target your needle over there accordingly. Well, I was talking about the ganglion impar block. All of you know that yes, this is something where if the patient has chronic persistent perineal pain and burning sensation, though people have tried many other events like advising the patient to put ice on the bladder area, to put ice on the perineum, but those are all conservative measures, but this is one which ultimately will require your attention, the ganglion impar or transsacrococcygeal innervation, or using your C-arm and putting the needle and getting that kind of the confirmation over there. But then, as Dr. Kumar was talking about, yes, that you need to sometimes think about all these different kinds of peripheral nerve blocks. Maybe you're not satisfied with the response that you're getting, and as we said that yes, pain is but one of a complex symptom experienced by chronic pelvic pain patients. So please look at the fatigue, the depression, and the sleep disturbances that these patients are experiencing. And of course, Dr. Subramaniam was talking about the laparoscopic release. That's what one of the entrapment of the for pudendal neuralgia, and many others attempts have been made, and even pelvic additional lysis, I would say. But let me tell you. But before that, yes, we talk about the coil embolization approach. This one report which appeared in 2006. This female with vulvar varicosis and with multiple varices with left-sided vulvar varicosities and insufficiency of the great saphenous vein, the coil embolization and liquid sclerotherapy of the varicose pelvic vein, they got good results with that. But we are talking about additional lysis. The problem with additional lysis is, although recently, in the last World Congress at Yokohama, there was a talk about from San Diego, Dr. Jones, RCW Jones. He has been working from La Jolla, that particular area of San Diego, and he has been using hyaluronidase barriers and all that, and many other things, multimodal approach. So, but even then that has not been very successful. So let us not forget that whatever attempt you may make or your surgeons may make in additional lysis, but after 2 or 3 months again patient comes back with the same problem. So people have not been very successful. This is what I was talking about, that I see that 2 or 3 of our patients who have been coming up for last 10 years, they have been coming to me very regularly. And the reason being, I have not been able to plan for the sacral neuromodulation or the retrogrades. One thing I'm sure, if you scan the literature, the evidence is very, very low, though Dr. Subramaniam can always enlighten me. It's a low level of recommendation. But in India, the problem is that cost of 3.5 to 4 lakh, which they are not able to afford. So this is where you find patient has frequency. The moment they come to the pain clinic, they say, please wait, I have to go to the loo, and then she comes back again. So the urgency is a sterile dysuria, always remember that. and cystoscopic finding of petechial hemorrhage and occasional ulceration may be there, and this is where we always start with a conservative approach and go on to a minimally invasive one. But then surgical ablation of the vesicular plexus and all those kinds, even avoidance of things like, I think it's in the next slide, also known as the bladder pain syndrome, a stepwise approach as I was talking about, the more conservative, less invasive first, and then go on to R.C. Jones I was talking about from San Diego. He was there in the last World Congress at Yokohama. So the initial patient education is very important, and that's where you always tell them, that use heat and ice packs actually so over the bladder, and perineum area, avoid caffeine, alcohol, pelvic floor therapy. Pentosan polysulfate, the only US FDA approved medication for interstitial cystitis. Pentosan polysulfate, though attempts have also been made that phenylpyridine and methenamine, amitriptyline is always there, and they have got mixed results with that. Dimethyl sulfoxide has been used, it has been approved. Hydrodistension of the bladder to the range of 60 to 80 centimeter of water again has been used. And more invasive one, if yes, again they are rarely used, cyclosporin A, the evidence is poor, but people have used cyclosporin A, urinary diversion by the urologist, the surgeon, and the sacral neuromodulation can always be done. Vulvodynia is another condition, sensation described as a burning, irritation, rawness and discomfort, and pathology will hardly reveal anything, but you have patient is so frustrated. One of the gynecologists herself, she actually presented to us, and I referred the patient to my dear friend Dr. Dureja over there, because there only she could actually ultimately he could convince her for sacral neuromodulation, and she got good results with that. Otherwise, yes, ganglion impulse block, all of them can be definitely attempted over there. I think I'll skip this one because you have a session tomorrow, but zoledronic acid for metastasis in patient with with these low cervical malignancies. And of course, people have also attempted for continuous intrathecal pumps, and especially when metastases are there. I think I'll skip this one because you have a full session tomorrow. But some attempt has been made on neurosurgical palliative intervention, selective lesion of the dorsal column in patients with intractable visceral pain and intractable pelvic pain have appeared in the past. But always remember that pain and depression go hand in hand, and this is where I'm sure the catastrophic events we must try to avoid and take care of them as far as possible, especially the hypervigilance phenomena and these kind of, the kinesiophobia which they have. And especially the catastrophizing events, and there's something which needs to be taken into account. We don't have much experience with CBT, but then yes, my colleagues in US, they've got wonderful results with cognitive behavioral therapy, CBT group therapy over there. One good editorial which appeared that you can't have one without another, although it appeared in 2007, any one regional chronic pain is more likely to occur in the presence of any other regional pain than in the absence of another pain. So are we getting anywhere in human pain genetics? I think this is something for last 7 or 8 years we have been working on that, and we have been focusing our attention onto signal transduction gene. Recently we have worked upon microRNA also, and now we are going on to apoptosis, and I'm sure when we talk of apoptosis, the latest one many of you would be knowing, we are focusing our attention onto autophagy, but that's in the pipeline. We are working on autophagy also. So I'm sure pain researchers have come very late to the genetics party. So you adopt a holistic approach to the treatment, and obviously I'm sure you can't ignore empathy, hope and ongoing support. So to conclude, I would like to emphasize that this is actually a headache in the pelvis or a migraine in the pelvis. We need to have a multidisciplinary approach, and visceral, vascular, myofascial and neuropathic pain components have to be taken into account. The pelvic floor forgotten, myofascial source, and integrated approach is needed, and appropriate intervention procedure needs to be adopted only when you are failing with the conservative approach. So only thing which I would like to add upon here is something which I think I can ignore this one. This was the year when actually the focus of ISP, though every year they keep changing theme, in 2007, 2008, it was against pain in women. Some of the newer therapies, this is what I was talking about. Just give me 2 minutes more with the permission of the Honorable Chairperson. Well, we are right now focusing on to targeted therapies, and that's where in the constipation predominant IBS, we always forget that when we're talking of pelvic pain, let us not ignore IBS also. And this is where guanylate cyclase agonist, and there are two ones which are there. I'm sure I'll have to read it out because the names are very complex. Linaclotide. Linaclotide is one, and another one is what you call it as polyethylene glycol. But polyethylene glycol, the evidence is very poor. With linaclotide, the evidence is good, and what actually linaclotide is supposed to be. I'm sure it is supposed to be guanylate cyclase agonist. So I think let us not forget that. And of course, we did talk about that. Yes, in IBS you need to avoid lactose, and you need to you also need to. There are some of the gastroenterologists, they always recommend avoiding gluten. Avoiding gluten when you have made a diagnosis or probable diagnosis of IBS. So I think this is something where you can normalize the bowel movement, and you can also, I'm sure, you can improve the composite abdominal pain score accordingly. So this is something I thought I must bring it out over here. And this is the latest one which appeared in 2017, Pain Physician. That attempts have also been made with the one which is not available in India right now, the 8% capsaicin patch, though I'm sure it's available in Europe, and I'm sure UK also it's there, but in US it is a little bit doubtful, but I don't know. It might have been approved. The 8% patch which they have used for patients with chronic pelvic perineal and gluten neuralgia, and the treatment would be particularly indicated in the management of also oxygodynia. So whatever I have talked about is simply the tip of the iceberg, but let us not forget the old Indian tradition of yoga and meditation in addition to all these multimodal approaches that you have taught. So I'm sure it will always remain an enigma, a kind of mystery, and which I'm sure all of you are going to solve. So our continuous research in this direction, I'm sure will bring about more focused, molecules and more focused interventions in the direction of management of, holistic management of chronic pelvic pain. Thank you so much. Sorry for taking extra time. Thanks very much indeed.
Thank you, Dr. Hussain. I think you've done the impossible feat of summarizing such a complex problem with multiple causes in 20 minutes and keeping in time as well. Thank you very much for that.
This is Info Media Prime Slot Network, and you're watching Prime. Your voice, your channel.